Good morning. This is Babak, Larian, here for a parathyroid Q&A. Hope you guys are all doing well and staying healthy. Strange days, strange times, right? We have a lot of questions. I'm really happy I'm able to do this, especially during these times where access to healthcare is even more limited. Parathyroid is a hard problem to start with. Hyperparathyroidism is incredibly difficult disease to deal with, to live through, and unfortunately to diagnose and get your voices heard. So during these times where I can help people all around the world get some answers and get a sense of direction, it actually is, I find this an incredible platform to be able to help on this scale. In any case, I'm going to go ahead and start here. Let's see. Let me start with our first question. All right. So, hello, Dr. Larian. This is from Shirley List. I've had 2 unsuccessful parathyroid surgeries. They are unable to find my lower gland. The other 3 are okay. Since 6 months ago, my calcium was 10.8, PTH 54, and vitamin D is 19.7. Last week, calcium was 10.5, PTH 145, and vitamin D 23. So the calcium is slightly above normal. PTH is ranging from high normal range at 54 to elevated at 154 and 145. And vitamin Ds have been low at both times because they're less than 30. So since my PTH is so much higher, would the adenoma be larger and possibly easier to find? Thank you for your input. I've been fighting this disease since 2003. Surely, in general, yes. So in the whole world of hyperparathyroidism, there is only one corollary that actually works. It's not that the level of your calcium correlates to the size of the tumor. Ironically, it's actually the PTH level that's directly correlates with the size of the tumor, and vitamin D level. So the higher the vitamin D, the smaller the tumor, the lower the vitamin D, the larger. So vitamin D is inverse to the size of the tumor, PTH is directly correlated with the size of the tumor. So, the fact that you have low vitamin Ds and your PTH is now higher makes it more likely that you could potentially find it. Having said that, if you have had for many years a low PTH, low normal or high normal PTH, meaning PTH in your normal range, and now this one time your PTH is significantly higher, then I would say you may not be able to reliably depend on that one number as singularly telling you that you are now having a parathyroid that has grown, because the number changes. It's a variable thing. It's not a constant, and so if any of the dynamics inside your body changes, you can temporarily have a spike in your PTH, and that may not be consistent. So I would say, Shirley, if you were to repeat your labs in a week, right? A week after that first one, the one that you got at a PTH of 145, and look at it again, and again that number is in the high numbers and above 100, then you can say, yeah, probably this gland is now larger. Perhaps it's time for me to do a scan and repeat the scans and see if I can find it. And I would say if you, again, ultrasound is harmless. So ultrasound is the best way to start, but a 4D CT scan, and if you have access to a PET choline scan, I think that would be potentially another avenue of trying to find where this abnormal gland is. So it's well worth looking into. All right, Mary Stanley Reynolds. I've been diagnosed with hyperparathyroidism. I haven't had surgery yet. I do strength training twice a week and yoga twice a week. My muscle mass is not increasing over the last 9 months as expected. Does this condition directly impact muscle mass? It doesn't it makes your muscles weaker, right? So Marat, it does make your muscles weaker. So if you have weaker muscles, I'm not sure how that correlates to the mass of them, but I would say you have to look at how your strength training is going. If you're able to increase weights, and if you're able to add more weights to it, and feel strong but are not increasing, then that probably is not related to parathyroid, right? But if you feel like there's a limitation to how much increased strength you can get, then that is probably related to hyperparathyroidism. Having said that, I haven't really seen any studies that have looked at muscle mass, right? Again, in that this is disease of women in later years, and the level of interest in body muscle mass increase is not generally that great in that population of patients. It's present. In fact, one of the best nurses when I was in residency was a huge bodybuilder, which really helped with the patients in the hospital. She was actually Miss Canada. She was amazing. But the level of interest isn't as much. So being that these researchers are looking at the general population when they're doing parathyroid surgery, I don't think any of them have focused on muscle mass as a focus point. They have focused on muscle strength and weakness, but not mass. So it could be there. It could be this. It's just not studied, you know, and that may be the reason. Having said that, I also will say that hyperparathyroidism affects the functionality of every system in the body. So muscles obviously are affected and it causes weakness. Increasing muscle mass in an environment where your body's working inefficiently will be a challenge, I would imagine. So I do think probably that does play a role, but I'm not certain. Paulette Furry Thornton. I just had 3.5 glands removed. I'm 66 years old. Sorry, I forgot my other computer to look at, so I have to look across. I have osteoporosis because of the years undiagnosed. I read that drugs from osteoporosis do not help if it's from your parathyroid. Do you think my osteoporosis will get better since the glands are removed? Thank you. I'm actually gonna reverse this thing and show you the good news. All right, so for a lot of you this will be repetitious, but it's well worth it. So this group of brilliant researchers at Columbia University in 1984 started a research project, right? They published the results in 2008. So over 20 some years of data they collected. They had 116 patients that came in and to the hospital, and they let them choose if they wanted to have surgery or radiation. Half of them chose surgery, the other half chose no treatment, not radiation, no treatment, observation, right? The calcium level was not too different. This group had a calcium 10.8, this group had a calcium 10.5. Interestingly, the PTH level was higher, significantly higher in the group that chose surgery versus not. And that I would say tells you that the higher PTH gives more symptoms, makes people feel worse. So that's why they chose surgery. In the group that chose surgery, and 100% of them were cured, these guys were good at what they did. At 15 years after surgery, the patients who had a successful surgery had a 10% increase in their bone density as compared to before surgery. So 15 years after surgery was done, the patients who had surgery, and this is without drugs or anything else, without a concerted effort of exercise and things like that, 15 years later, this group of people had 10% higher bone density as compared to before having parathyroidectomy. So the good news is that your bone density is going to improve. And I would say, unless your bone density is dramatic and you're getting fracture after fracture despite having had surgery, I would say stay away from the medications, right? And do reasonable increasing weight exercises. So you put weight on your bones. Our body is designed for adaptation. If you put weight on the bones will get stronger. If you don't put weight, if people are bedbound and not moving, their bones will get thin because there's no reason for body to put resources in what's not being used. And so I would highly encourage you to proceed with exercising and weight-bearing exercises. If you go for walks, put the weights on your arms and walk with the weights on. Do some light weightlifting, but make sure you put some weight on the bones and force them to get stronger, and they will. The study shows it. I'm going to show you one other thing that I think is very interesting about this study, is that in the group that did not get treatment, the 11 patients actually died in the time period they were looking at, right? And interestingly enough, those 11 patients actually had a much higher PTH level. The calcium wasn't much higher, their PTH was. And all of them died from heart-related conditions. So just to kind of show the gravity and the importance of getting this disease addressed, it's just so vitally important. In any case, moving on. Cat Hill. Dr. Larian, another question, curiosity if I may. Many women report worsening of their PHPT symptoms before menstruation. I read that calcium rises during the luteal phase of a woman's cycle. Could this be the reason for the worsening symptoms? Yeah, I mean that would make sense. I'm not sure how that process works. So during the hormonal changes, there must be a estrogen or progesterone sensor on the parathyroid cells, or that affects calcium levels, and I wonder why that is. I'm not sure the reason, but that's interesting to know, Kat. But that would make sense. You know, if the calcium elevation is also caused because there is elevation in parathyroid hormone, then that would make even more sense, because a lot of the symptoms are due to the PTH itself. So if there's a rise in calcium caused by a direct impact on the parathyroids, there could also be an impact on the bones. That could be the hormonal changes are directly impacting the bones, and the bones are releasing calcium in preparation. Anyways, thank you for that input. I haven't thought this through, and I haven't read up on that aspect, but that makes it interesting. That's good to know. I'll try to see if I can find some info on that. Donna Davis Amonette, ectopic parathyroid adenoma placements. A normal case of hyperparathyroid which show adenoma attached to the back of the thyroid. How often are they found behind the aorta? How often are they located behind the voice box? What other rare places have adenomas been found? Okay, let's see. Let me flip you around. So let's talk. All right, so adenomas are in ectopic positions because the fetus during the first 5 or 6 weeks of life, inside the throat of the baby, they make these pouches, right? And it's happening on both sides, right? And these pouches, ultimately, the first one turns into the ear. So this becomes the eardrum right there. So outside, and this is the inside. This second pouch here turns into the tonsils in the throat. The third pouch turns into the lower parathyroid and the thymus gland. So they migrate from here in the throat, just underneath your tonsil, and travel all the way down in the neck. So My tonsil is up here, my thyroid is down there. So they develop here and they migrate down. So the third pouch migrates to the lower parathyroid all the way down there. The fourth pouch travels to the upper parathyroid here. So there's a migratory route, right? And in doing that migration, sometimes the thymus and the parathyroid kind of merge together as they're coming down, and so the parathyroid hides inside the thymus. Sometimes it overshoots and passes the thymus and goes and lays around the aorta, right? And sometimes the two parathyroids, as they're coming down, merge. And so 3% have only 3 parathyroids, 2 on one side and 1 on the other. And sometimes as it's coming down, it leaves pieces behind, right? So this particular person will have 1, 2, 3, 4, 5, 6, 7, 8, 9 parathyroids, let's say, right? Without the additions of what I did, this person had 1, 2, 3, 4, 5 parathyroids. So anywhere between 3 to 20% of people have 5 or more parathyroid glands, right? Okay. So some of the ectopic locations. So for the lower parathyroids, majority of times you find them here behind the thyroid gland. So this is the thyroid gland, right? And this is the thymus. And so, but 40% of the time it's right there behind the, another 40% is right at the upper tip of the thymus. So it's in the neck between thyroid and parathyroid. 2% of the time it's inside the thymus, right? This area here, the connection between the two is called the thyrothymic ligament. So it's in that attachment between the thyroid and the thymus. Another 15% of the time it sits further back on the side next to the breathing tube. This is the breathing tube. This is the voice box, right? And 2% of the time it goes further back. So that's for the lower parathyroid. The upper parathyroid has a more consistent location because it travels less of a route. So 77% of the time it's right on the back there, another 20% up, further up, and about 1% of the time it goes behind the esophagus or breathing tube or trachea and so on. So it's rare to have it go down into the chest, right? 2% of the time. Goes all the way down into the chest, and it can be anywhere in the chest. I've seen it to be mostly right on top of the aorta or in front of it. I have not seen it behind, but those are the locations where you can find it in, Donna. Okay. And I've seen it stay up all the way up in the throat. There's a report of it being inside the throat, where they could actually see it as a bulge in the throat underneath the tonsil. I haven't seen that, but I've seen pictures of it on that one patient that was reported on. I have found it all the way up here, and I found it in the chest. I found it in front of the aorta. Even closer to the heart. I found it behind the throat and the voice box. That's not too uncommon. That's kind of a relatively, I would say, more common finding that it sneaks. And it's not completely behind. It comes from the side and goes behind. So it's somewhat behind and somewhat to the side. I see that a fair amount. I would say that the upper parathyroid tends to do that more. Tends to sneak in behind, and the lower parathyroid tends to go lower when it's in an ectopic position. That's generally the way they behave. Now the upper parathyroid can also migrate too much, and when it does, it usually is next to the esophagus or the tube that goes to your stomach, and a little bit to the side, but deeper. So the upper parathyroids tend to be deeper, the lower parathyroids tend to be a little bit more superficial. Sherry Brian Farr. Hello, Dr. Larian. I've had an average calcium level of 10 for the last 6 years, and for the very first time, my PTH level is at 68. I tested it one other time last year, and it was 51. I take vitamin D3 and keep my levels up since I do not have a thyroid. If I let it fall too low, I would get sick easier. Should I consider parathyroidectomy? I'm very confused about all this. We only go on labs. Then when one is ready for surgery, whether or not a person has a tumor, the parathyroid gland or glands still are removed. Okay. All right, Sherry. First, yes, the diagnosis is made based on labs. And it's hard for me to answer you like this. I would have to see each calcium and PTH and vitamin D number at the same time. So if you make a table for yourself and look at the calcium, PTH, and vitamin D, that'll make it a lot easier for you to be able to get an answer that's meaningful, because you can see the relationship. And the way you diagnose it in cases like yourself, when the calcium is not high and PTH is not high, is you look at the relationship. And in a normal parathyroid environment, again, let me show you. In a normal parathyroid environment, there is, so on the surface of the parathyroid glands, there's a sensor on the surface of every cell called the calcium sensing receptor. And this receptor attaches, obviously, calcium. It's a calcium sensor. And when there's enough calcium attached to it, it stops PTH production. So that was PTH, right? So the relationship between calcium and PTH is this curve, right? And so we all have what we call a calcium set point, right? So that's the dot right there. So you're born with that set point. You're going to always try to keep that set point. For this particular patient, that set point is 9.5, right? And so when there's a slight deviation from 9.5 to 9.4, there's a 30% increase in PTH level, right? So you go from 50 percentile to 80 percentile of PTH production, right? And by doing that, the PTH goes to your bones and tells your bones to release calcium. Your calcium goes back towards the 9.5. By the same token, if your PTH goes from 9.5 to 9.6, there's a drop in PTH also. So 20-30% drop in PTH, allowing your calcium to go back down to the 9.5. So here, the calcium PTH produced increases the calcium to 9.5. Here, the lack of PTH allows the calcium to be filtered by the kidney and the calcium to go down to 9.5, right? So there is this relationship normally, right? So when you look at a person and look at their labs, you're going to have changes like this happening. And when changes like this happen, you over the years, when you look at their numbers, right? And let's say your particular curve was at about 10, right? So let's say this is a 10. This is a 9.5. This is a 9. That's a 10.5, right? Let's say this is your particular flavor, right? And so if your set point now, because you have a tumor, is if you were normal and your set point was at 10, right? You should have some days where your calcium is 10.2 and your PTH is low. Your PTH would be, 15, right? And then there would be days where your calcium would be 9.8 and your PTH would be 60, right? And you're going to have this variability based on what you do. So if you were to exercise and put weight on your bones and your bones would try to grab calcium out of the body, right? During the time period when the calcium is being drawn out of the body, your calcium would drop and your PTH would go up in response to it, right? But if you had a lot of vitamin D fortified milk, right, and the amount of vitamin D, calcium in your body increases, then all of a sudden you'll have calcium level that's now more than 10.2 10.0, it's 10.2, 10.3, and your PTH that's gone down. So the variability is meaningful because it tells the person that they are having a normal functioning parathyroid. Now, when you have a parathyroid tumor, this is what's happening. So this particular person, their normal is 9. They get a mutation in the processes surrounding the calcium sensing receptor for one cell. So that one cell now has a set point of 11 as opposed to 9, right? So the normals are all at 9 and this one is at 11. As calcium comes up here, the normal cells go through the curve and stop producing PTH, right? While this one that's aiming for a higher number is working harder to get you to that, right? And in time it duplicates, it gets bigger and bigger and bigger and bigger, right? So, you know, if you have this process going on, then, and let's just change it to your version of it. Instead of 11, let's say you are hovering like that, around 10. So someone who's trying hard to stay at 10 while the rest of the body wants at 9.0 is going to have calciums that are close to this number, go from 9.8 to 10.2, 10.1, something like that, and PTHs that are mostly working hard, so they're all consistently on the upper side of normal or elevated. So if you have a lack of variability where your PTHs are always a higher number, that also clues you in to the fact that probably you have hyperparathyroidism really creating this issue, okay? So I think that's part of the problem here. Let me go to the next question. So I think the most important thing, again, I'm not going to the next question. The most important thing is for you to confirm the diagnosis by looking at these numbers all together. Should you consider parathyroidectomy? Well, I have to say one thing. I'm not clear on your diagnosis. Even though your numbers for calcium and PTH look suspect, the fact that when you don't take vitamin D, you feel bad, concerns me, especially because you've had thyroidectomy before, because I wonder if your whole system, if your parathyroids are working properly, right? So I think I would need more clinical information to give you a better answer, is basically what I'm trying to say. And then you ask if one is ready for surgery, whether or not a person has a tumor, are all glands removed? Absolutely not. I think your particular case is somewhat tricky, is not the best word, but sensitive, because you've had previous thyroid surgery. We don't know how many of your parathyroids survived that surgery. So of the 4 parathyroids, all 4 could be working, 3 could be working, 2 could be working, or 1 could be working. You don't know that functionality. So for you in particular, it is absolutely vital that you get an expert surgeon doing your surgery, right? Hopefully the one who did your thyroidectomy has a lot of expertise in parathyroid because they'll know your anatomy best. But if not, get a parathyroid expert to do it. And make sure they have intraoperative PTH testing, okay? It's vital for you in particular during surgery, because if all 4 of your parathyroid glands were close to the thyroid gland during the surgery, and 2 of them got scarred and are not working, right? So you have 2 functional ones, and one of them is abnormal and the other one is normal, let's say, right? And they go, during surgery, they'll find both of them and take out the abnormal one, and you check your PTH, but the PTH numbers, and the PTH numbers are good, you know, let's say you start at 60 and the PTH numbers settle in at about 15 to 20 and stay at 15 to 20, then you know that one last gland is healthy and normal, you're going to be totally fine. If on the other hand, they take the abnormal one out and you have one left behind, and they check your PTH and it goes from 60 to 15 to 5 to 0, that means that the amount of work that last one is doing is not adequate. And so your surgeon should look at that last parathyroid. If the surgeon looks at it and says, yeah, there's enough tissue, and biopsies and proves that it's a parathyroid, but it's not working enough, then that the surgeon may want to take that parathyroid out, cut it into little pieces, and reimplant it in the muscle. So it's important that you get someone who's thinking this process through, okay? But in a regular circumstance, when all 4 parathyroids exist and one is abnormal, we only take out the abnormal one, right? Some may want to look at the other 3 just to be reassured. I feel like looking at it physiologically rather than visually to see how much hormone it produces is more meaningful. So I check hormone levels, right? PTH levels. Because just looking at it is not telling enough. If the PTH levels show that you continue to have, despite taking out the culprit, right? You continue to have high PTH levels, then one of the other 3 is abnormal. That's when I would go looking at them and risk potentially damaging 1 or 2 of them, right? Sherry, I hope I haven't added to your confusion, but I think you really need more detailed, I would need more detailed information to be able to effectively help and answer your questions. But I suspect that you do have it, but I'm just not certain, okay? All right, Cat Hill, back again. I would like to ask you about boron and primary hyperparathyroidism, okay? Specifically, urine calcium excretion. I read that boron taken in postmenopausal women can help promote bone health by reducing calcium excreted in the urine, okay? However, in the case of PHPT, could boron supplementation and the lessening of urine calcium to increase the calcium has to go somewhere? Potentially, if somehow boron gets in the way of filtration of calcium in the kidney, and you have hyperparathyroidism and the kidney is not allowed to filter, which it really isn't, because parathyroid hormone also decreases filtration of calcium in the kidney. So if you add boron to it, it would actually compound the problem, I would imagine. Boron has made a marked improvement in pre-op PHPT symptoms and most notably increased stamina, energy, improved cognitive function, focus, and comprehension. However, my calcium has risen from 2.93 to 2.96 since supplementing. Could this be due to less calcium being excreted in the urine due to boron supplementation? I mean, I'm trying to think. I mean, I'll have to obviously look and see what I can find with boron but if boron is making you feel better, and it's also at the same time increasing your calcium, it must be impacting your PTH levels, and it's allowing the PTH levels to come down and not filtering the calcium quite so much. And so by not filtering the calcium and allowing more calcium in your bloodstream, your tumor doesn't need to produce as much PTH, and because to keep the calcium at that higher number, and because it's not producing as much PTH, you may be feeling better. I mean, that could make sense. I obviously can't promote using the boron or anyone using the boron because I don't know the impact of it. But obviously, if it's making you feel better and you're close to having surgery, I think it should be okay. But it's an interesting thought, and I'll really have to look at it in more detail to see where that comes in. All right, thank you, Kat. Thanks for educating me. Jackie, hello, Jackie. Nice to see your name here. Hope you're well as well, Jackie. If a surgeon has unsuccessfully attempted to take a mediastinal adenoma through the neck with some thymus, is it imperative to have chest surgery for the subsequent third reoperation? Thank you, Jackie. Yeah, I would say so, Jackie. If you just cannot reach it, I'd have to say it has to do with the expertise of the surgeon. And the anatomy of that particular person, the patient, the person who's suffering from hyperparathyroidism, because some people have shorter and more compact bodies, and some people have a long, stretchy body, right? And so The neck for some people is long and then for some people is short and stocky, I would say, right? And those are two different patients to operate on. It's a very different surgery when you are in those circumstances. And so that in and of itself is a factor for this person, and the experience of the surgeon, how willing they are to go from the neck into the chest. So under the circumstances, if 2 attempts have been made already to to get in there and take out that parathyroid, and it could not be reached, I would say approaching it through the chest would be probably a good idea, or having at least a chest surgeon maybe look from above. And the chest surgeon is the person to tell you which approach is appropriate. But I know a lot of people are using robotic chest surgery to access the parathyroids, or are using cameras from up here to get down to it. So I do think you need a chest surgeon involved to help guide and make this decision. All right, here we go. Doreen Babak. Let's see. Hello, Dr. Larian. Question: if no adenoma shows on a system EB or a regular ultrasound, is it still possible that I have hyperparathyroidism? My last 3 labs. All right. First and foremost, you do not diagnose hyperparathyroidism based on scans. You diagnose based on the relationship between calcium and PTH, right? So looking at your numbers. My last 3 calciums, 10.3, 10.6, and 10.0. So when your calcium was 10.3, your PTH was 48. So slightly elevated, but if you consider the top of my head being the normal range, your calcium is slightly above the range of normal, right? And your PTH at 48, normal range of PTH is 15 to 65. So your PTH is here. Your calcium is elevated slightly, your PTH is here. It should be down there in a normal parathyroid environment, right? Then the next one, your calcium is 10.6. It goes higher, your PTH comes down to 38. Goes down a little bit. It doesn't go all the way down, a little bit. Still not appropriate. The next one, your calcium comes down to 10.0, upper range of normal. Your PTH shoots up to 51, right? So clearly your parathyroid tumor wants your calcium to be somewhere between 10.2, 10.3 area, would seem, right? And vitamin Ds are 30, 23, and 39, right? So vitamin Ds were, how interesting. Very good corollary for you, I would say. When your vitamin D is lower at 23, right, your PTH your calcium goes up to 10.6. And when your vitamin D goes up to 39, 39 suppresses PTH, right? But your PTH is the highest. Anyways, I have multiple kidney stones, osteoporosis, osteopenia, fatigue, racing heart, etc. I'm 61 years young. I love that, Doreen. Yes, you are 61 years young. Listen, based on the numbers, I would say you have hyperparathyroidism. They would call it your version the normal hormonal, because mostly your calciums are elevated and your PTH is in the normal range. You have hyperparathyroidism. However they label it, it is hyperparathyroidism. And you have multiple symptoms and kidney stones and osteoporosis, so you really need to take action. The fact that the system EB and ultrasound are negative are not surprising. Your parathyroid tumor is on the smaller size because your PTH, your highest PTH you had is 51. So the size of the tumor is small, or you may have hyperplasia. There's a 25% chance that you have multiple glands being infected, so hyperplasia, and 75% chance that you have one singular adenoma, right? And so I would say 75% chance that you have a very small adenoma that not active enough to show up on a system EB, small and may not be visible to an ultrasound. So at this point, my suggestion to you is to do the 4D parathyroid CT scan, because you certainly do have hyperparathyroidism, and because you have osteoporosis and kidney stones. It should be something that at the young age of 61, you should definitely take action so that you can continue to have energized, motivated remainder of your young life. All right, Doreen, hopefully that helps. Donna Davis, Donna again. My scan showed an adenoma right above my heart. During the robotic surgery, they saw nothing. My scan was wrong. They did go ahead and remove my thymus and cleaned up some fatty tissue in the chest. How often are scans wrong? What are the best accurate up-to-date scanners available, and where are they? Well, so it depends on which scan. Well, obviously it wasn't an ultrasound because it wouldn't show it over your heart. If it was a sestamibi, I would say sestamibis are problematic a little bit. They especially when your PTH numbers are not so dramatically high, they can be inaccurate. 4D CT scans can be inaccurate. You know, there's sometimes that you see extra pieces of thyroid that look like a parathyroid. Sometimes you have an activated lymph node that's, you know, inflamed and so on. It has a lot of blood flow through it, and that may look like a parathyroid. Sometimes thymic tissue that's separated also may look like that. And so I would say all of them are prone to problems. The latest parathyroid scan that has come about is the choline PET scan, and the choline PET scan is available, as far as I know, at least in California. It's in the University of San Francisco, UC San Francisco, University of California, San Francisco, at their main hospital they have it. It's part of the research protocol, so it is not easy to get it. So you have to have a consultation with other doctors and get yourself enrolled in the research protocol, because it's a newer technology. Now I would say the PET scan machine is not new. It's the radionuclear isotope that they use has not yet been FDA approved for this particular purpose. It was FDA approved for prostate cancer, and so they had been used for prostate cancer. So that's why it's not readily available. And so that's why it's part of the research protocol, at least in the US. I know in Canada, Dr. Palazzo does have it at his hospital and does tend to use it a fair amount. So I think that's a resource if you're in the UK. All right. Best of luck, dear. Katie Willis Walton. The surgeon that I'm going to be seeing late because of lockdown, his specialist field is breast cancer. He has operated on me a total thyroidectomy approximately 6 years ago. Thyroid and parathyroids are his interests. I'm feeling a bit apprehensive for him to remove an adenoma. I have hyperparathyroidism, and this is not his specialist field. I'm in the UK. Should I be asking for a doctor that specializes in parathyroids? Katie, very good questions. Normally, I would say that you should, but let me explain. One generation before me, most of the parathyroid surgeries were done either by ENTs or general surgeons that had a focused interest in cancer, right? They were surgical oncologists, right? And a lot of surgical oncologists would choose either the two paths. One path is radical, big surgery, like, you know, taking out liver cancer or pancreatic cancer, intestinal cancers, big cancer surgeries, or the path of the smaller, more controlled cancers. Thyroid cancer tends to be a less aggressive cancer. Breast cancer is not as radical because it's not an internal organ, it's a more superficial organ, right? So these patients tend to do better, fortunately, as compared to someone who has pancreatic cancer and needs the surgery. Pancreatic surgery is exceedingly challenging and difficult to recover from. So the last generation behind me, there was a combination of breast surgeons doing thyroid parathyroid surgery, and that's not an uncommon thing, actually, right? And the reason I'm explaining is because the surgeon that did your thyroid surgery is probably one of the best people to be doing your next surgery because they are familiar with your anatomy, right? And so what I would suggest is that you ask if they're doing PTH testing in the operating room because you're having repeat surgery. If they are not, if this surgeon is not doing PTH testing in the operating room, then that's not the person for you. And if you're in the UK, I have only seen Dr. Palazzo operate. So I can only vouch for him because I've seen him be a skilled surgeon and do things the right way. And so I would suggest that you see him if your own particular doctor is not doing PTH testing during the operation. For you in particular, just like I explained just right now, after a total thyroidectomy, it is not very clear how many of your parathyroids are still alive. And so because of that reason, you need someone to be testing physiologically how your parathyroid glands are functioning after they remove the adenoma to make sure the remaining glands are operational. All right? So best of luck, my dear. It's a hard thing, Katie, but I really wish you the best. Dominic Jashong. I know I massacred that name. Anyways, question. Have calcification islands in ligaments on feet, finger, joints, and invertebrae, and metatarsal. Is this hyperparathyroidism side effects or isolated? Well, it could be that. It could be part of a condition called calciphylaxis, where you get calcifications inside your body because of such an increased calcium level. But it also can happen without hyperparathyroidism. If it's related to hyperparathyroidism, then it's good news, because majority of times when you reverse the hyperparathyroidism, as your body's going through its regeneration of tissue, because as you know, every part of our body keeps getting regenerated. So the lining inside the mouth completely replaces itself every 2 weeks. All right? So the whole surface of your mouth replaces itself every 2 weeks, because it's constantly going through processes of trauma and healing and repairing and trying to fix itself. So because of that, a lot of times those lesions improve, but it's hard to predict which ones do and at what pace. All right, but I think the most important thing, Dominique, is to figure out the diagnosis. Donna Davis Amonette. Another good question. Knowing that the parathyroids are calcium regulators and the thyroid regulates metabolism, is it possible for the parathyroid gland to grow inside the thyroid? Yes, it is, but not for the reason you're mentioning. The reason they do is, allow me to flip you around and show you. Right, so here we go. The reason that happens is back to so again, parathyroids develop from pouches in the throat. The thyroid gland, ironically, develops from the back of the tongue. So all the way in the back of the tongue, there is this thing called foramen cecum. It's a hole. And that hole, during the same time period, develops and turns into a pocket. And that pocket, in time, comes down and becomes the thyroid. Right? And so as this migration is happening and the thyroid comes down, there's other pieces, we'll color them pink. There's other pieces that come and attach the thyroid from the side, right? These are what produce what's called the C cells, or the calcitonin producing cells. And as they are coming and attaching and merging into the thyroid, if the parathyroid, which we'll draw in blue, was here as this is happening, these purple cells would force them into the thyroid. Sometimes the thyroid itself, as it's coming down, may just trap the parathyroid itself without the pink cell involvement, the C cell involvement, right? So that happens. It's not very common. Most of the time what I've seen, instead of the parathyroid being fully inside the thyroid gland, so instead of me seeing a parathyroid that's smack in the middle of it, what I mostly see is parathyroid that's just in the grooves and crevices that, let me do a better job. So you see the parathyroid kind of merged on the surface, and I remember all organs in the body have a covering called the fascia. Another name for it is a capsule, right? So it could be that the parathyroid is inside the capsule of the thyroid, and I see that more often. And because the capsule is uniform, you may not see that parathyroid in there, and that may be the cause of it. All right? All right, here we go. All right. All right. So, La Belle Jupiter. Hello, Dr. Larian. I had 2 glands checked. 2 glands removed in March of 2019. I have hyperplasia according to the pathologist report. My PTH was more than 200 last year. It went down for some time after surgery, but it has been rising since last year. I was normal calciumic for some time too. Now my PTH is 96. My calcium is 9.97, 10. I'm feeling exhaustion, brain fog, nervousness, fogginess. My local endo is scared of me having hypocalcemia after surgery. He's just taking Sensipar. I still have 2 glands. I'm in my 40s. I do not want to take Sensipar for the rest of my life. There is no 4D CT scan in my country. No imaging test showed any problems with any parathyroid glands last year before my surgery. Thanks for your input. Okay. You raised some amazingly important questions. I would say this is really actually a very good question and a very good thing, subject to talk about. All right. So when you have hyperplasia, that means all the cells in all the parathyroid glands are abnormal, right? Actually, let me flip you around and show you. Now, we have this notion of hyperparathyroidism and hyperplasia being, let's see if I can find it for you. Right? Being a very consistent thing, right, where all 4 glands grow the same amount, I find that to be rarely the case, right? Exceedingly rarely. And more often I see that happening in someone who had kidney failure and then all 4 glands at the same time started having the same problem. Otherwise, most people who have hyperplasia, they have it because of a genetic reason, or lithium medications, or potentially other toxins that we're not aware of, or radiation exposure. But most have a genetic base to it, right? And they grow at different rates. So we call it 4-gland asymmetric hyperplasia. And this is a representation of one, all right? So you have 3 glands that are enlarged, but they're all different sizes, right? And a 4th gland that is abnormal under the microscope, right? But much smaller than the other ones. So this gland has a slower growth rate than these, right? So if your surgeon went in there and saw 2 parathyroid glands that were this size, right? If these 2 were that size, and obviously these 2 are larger, and took out these 2, then your surgeon left 2 overactive glands, right? That just had a slower rate of growth, right? And in time, these 2 would obviously grow in size and give you trouble, right? Now, if your surgeon biopsied, put a little metal clip and biopsied these glands, right? So just biopsied this portion, right? And in doing so, confirmed for you that he or she actually found all 4 parathyroids, right? Then you know the 2 remaining parathyroids that are location, right? In which case, then a repeat surgery can be done where the surgeon, preferably your original surgeon who knows where those glands are, or if not, someone with expertise can go in there and find those particular parathyroids, see which one is larger and which ones are alive and viable, and make a decision about removal, right? Yes, the concern is real for having hypo, but at the age of 40, having a lifetime of Sensipar is also, we don't know what a lifetime of Sensipar does. We know it brings your PTH level lower. It doesn't seem to improve the health of the bone. You know, the issue is that the Sensipar suppresses your hormone production. That's true, and that's helpful. But the way parathyroid glands, the way all glandular structures work, they react to the body's needs, so they go up and down. And if you're constantly suppressing the gland and it doesn't have that variability available to it, then it's not a very functional gland. It's working an uphill battle in a sense, and so it's not ideal, right? So I would say if there was biopsy done during your original surgery, so you know the location and confirmation that both were parathyroids, then doing another surgery with a scan that's not showing anything is doable, because you know where they're going to be. You know that it's not hiding all the way down in the chest. There are 2 that were seen and biopsied in the neck, 2 that were removed. Hallelujah, right? If they were not biopsied, you're in a little bit of a more challenging situation, because you're depending on that first surgeon's visual inspection of a gland, which may be 100% accurate, maybe not 100% accurate, okay? And so it's hard to judge. If the surgeon didn't biopsy it, then I would do everything personally. If you were my patient, I would do everything I can to see if I can visualize them. And I would start with an ultrasound. I would certainly move to a 4D CT scan. I'm not a huge fan of the Custom UV scan, although I use it sometimes. I'm just not a huge fan of it. So I would do the 4D CT scan, and if that's not fruitful, I would do the Custom UV scan. If that's not fruitful, then I would do the choline PET scan. And that sounds like a lot of radiation I'm exposing you to, right? But that would be in every effort to try to prevent you from becoming hypocalcemic, right? Now, having said all that, most people cannot do all the things that I said, right? It is exceedingly hard for me to get patients to UCSF to get that PET choline scan, right? I just operated on a patient she's incredibly resourceful and got the job done and got the scan, and the scan didn't show anything because she had hyperplasia, right? And none of the scans, majority of times, show anything when you have hyperplasia, right? And so if in fact that's the case for you, the scans may not ultimately prove to be helpful, right? So, but what is your doctor trying to do, right? Let's flip you around again. Your doctor, let's just say during your original surgery, your surgeon took out these 2 glands, right? They're gone. Now, and you know which glands these are, because on your pathology report it says this is the right upper and the left lower that were removed, right? So, and visually inspected these other 2 because they were smaller and left them in place, right? So if I were your surgeon, what I would do is I would come in, and I would say I would come in on, if the ultrasound, let's say any of the scans show this one to be visible and this one not visible, then I would do the surgery on this one. I would go in there, find this one, see what it looks like. If it looks rounded, see, these really abnormal glands are more rounded, right? They're plump and rounded. If it looks plump, rounder, a little brownish in coloration rather than yellowish, fatty in coloration, then what I would do is I would remove this gland and check your PTH level. So if your PTH level starts at, let's say, 50, you remove this gland and the PTH at 5 minutes goes down to 15. At 15 minutes is 12, and at 20 minutes is 10. That means the PTH came down and is plateauing. Then I know this remaining gland is functional enough for you to be okay. You're not going to have hyperparathyroidism, and I don't need to go look for it, right? You may need 30 years from now for someone to go look for this one, but at least you haven't disturbed it a second time around during surgery. On the other hand, if your calcium starts at 50 and you check and your PTH goes from 50 to 45, 42, and 40, then you know this gland is really super functional also. That's when you need to go look for it and try to find it and remove it, right? And the third scenario is if it starts from 50 and it goes to 9, 2, and 0, then you know this gland doesn't exist. During the last surgery, it got knocked out. This was all you had, and at this point, your surgeon should go and take half of this gland, cut it into little pieces, chop it into little blocks, insert it in the muscle so that it can start working. So again, that's why you need an expert surgeon doing this for you so that you can, and you need PTH testing during surgery without exception, so that you can get the best possible results out of the surgery without guesswork, okay? Hopefully that's helpful. All right, moving on. Good luck, LaBelle. Sarah Vasquez DeVito. Hi, doctor. Do you do an albumin correction to find true calcium numbers? Is this corrected number what we should be looking at in terms of finding out what our calcium level really is? I mean, I do get it, and I do try to correct the calcium number, especially when the albumin number is dramatic, like so very low or very high. But I really mainly and mostly look at the relationship between calcium and PTH to try to figure out what I'm doing. You know, I find that to be more helpful than an absolute number. I look at the absolute relationship between these things as opposed to the absolute calcium to say, oh, your calcium is high, or no, your calcium is not high. Okay, so that's generally what I do. But obviously, you gotta take every factor into consideration. So I do get that number as well. Chantel Nielsen. I have a lot of the awful symptoms. I was diagnosed with familial hypercalcemia, hyperparathyroidism. Had 2 parathyroids removed. Was told that is mutated gene and I can't do anything about it. Is this true? It's all genetic and I have no control over it. Well, yes and no. I find that most of my patients who have hyperplasia have a genetic base, right? And the reason for it is for every cell in every parathyroid gland to be abnormal, there has to be a reason for it, you know. And for people who have kidney disease, it's the lack of vitamin D, because vitamin D suppresses growth of parathyroid. So when vitamin D is not there to be activated by the kidney, the parathyroids grow, right? Because there's no check on it. Lithium medication seems to affect that growth control, and they grow. But most other people who don't have a reason to have hyperplasia usually have a genetic base. Now, if you already have a genetic base, if you have family members that have had it and you've checked your genes and you have a mutated gene that you know, then yes, all of your parathyroid cells are abnormal, but you are just like everybody else who has hyperplasia. You're no different, right? And the treatment for you is exactly the same as everyone else. The treatment is to reduce the number of abnormal cells, right? So again, let me flip you back. Sorry, I guess keep seeing me up close, right? So if you're in the category where all 4 of them are really big, let's say all 4 were like this, right? Big, all 4 of them, right? Then what you have to do, what the surgery is to remove 3.5, right? Because you're trying to get to a parathyroid that is the size of a normal parathyroid. So let's say a normal parathyroid is this size, and you have something this big, right? Let's say this one is supposed to be this. Then what I would do is, in this particular patient that has all these 4 plump parathyroids, I would go and cut this parathyroid here, right? take this out, this out, this out, right? Cut this parathyroid, right? If this is a normal size parathyroid, I would cut and remove this portion and leave this in place, especially if this part is where the blood vessels are coming in, right? If, on the other hand, the same scenario exists, the blood vessels are coming from this end, right? Then I would do this and remove this portion, right? So I'm giving you somewhat of a normal size parathyroid left behind so that you can have a normal quality of life, a normal size parathyroid that for years and years is not going to be large enough to overproduce. That's what I would do, right? On the other hand, if you had asymmetric hyperplasia like this person, and this gland is the smallest and it's close to the size of a normal gland, then what I would do is if the blood vessels are coming again this way into it, then I would do a little biopsy here, remove the tiny sliver to confirm that this was a parathyroid, but leave it in place after I've done the biopsy and remove these three. I check your PTH level to make sure that what I've left behind is functioning, and you'd be okay. And that would be the strategy to treat someone who has hyperplasia. So I don't think you need to be fearful. I think what you need to do is just have the right surgeon do the surgery for you. And that's the basics of it. You know, have an expert surgeon do the surgery for you so you can have good results. All right. So the genetics of it, the genetics of it is obvious. You have it genetically based. That doesn't change the treatment. That tells you that you should do the genetic testing if you haven't done so already, so you can do it, see if you can figure out the gene, then you can tell your children which one of them have this and should watch out for having hyperparathyroidism, right? And if you don't develop the gene, then all your kids are at risk, and they should all be watching for it to be ahead of the game, in a sense, okay? Catherine Tolad-Zemanek. I developed a rash post-op and it occasionally comes back. Could it be because I'm hypocalcemic? I don't think so. I haven't seen a rash with hypocalcemia. I've seen rashes with allergies to surgical suture or tape that's used and so on and so forth, but I haven't seen it due to hypocalcemia. I have seen on rare occasions people develop rashes afterwards, and I really think that's part of the adjustment period of the body with changes and shifts in the skin and the immune system causing reactivity, right? But I haven't seen it due to hypocalcemia. All right, Fiona Ferguson. Just curious, but please, is it possible to carry out parathyroid transplants? I love the question. I wish I had a good answer for you. And the reason for that is, again, a parathyroid transplant is not commonly done and not feasible because first and foremost, you're taking someone else's body organ and putting it in your own, right? When you do that, your immune system recognizes that as something foreign and attacks it and tries to destroy it. So in order for us to prevent that from happening, we have to give patients who've had a transplant from another person they have to give them high levels of medications to suppress their immune system. That high level of medication to suppress the immune system generally is very hard. These are hard medications which make the person prone to infections and cancers developing, right? And so the balance between doing a parathyroid transplant and taking 2-3 immunosuppressive medicines that can allow you to develop cancer and infections as compared to taking calcium and vitamin D or injections of parathyroid hormone, the balance is more in favor of doing that than the transplant. Now, if someone has had a kidney transplant, is already taking suppressive medications for their kidney transplant, has hyperparathyroidism, so if they've had an organ transplant, already a heart transplant, liver transplant, usually a kidney transplant, because those are the patients that have parathyroid problems and need parathyroid surgery and could be left with hypoparathyroidism, they are already on that medication. It makes sense to do a parathyroid transplantation as well, right? But I would say is the only scenario where it would make sense. All right, let's see. Susan Marone. What is the long-term impact of having 3 or more hyperplastic glands removed? Is there any data about how patients are doing 5 to 10 years later? What is the worst-case scenario if all glands are either removed or stop working post-surgery? Well, the data that's out there is that if an appropriate surgery is done, or the patient is left with a functioning parathyroid that's producing adequate amounts of parathyroid hormone, a large fraction of those patients actually go on to have normal lives and not develop hyperparathyroidism, because the last remaining gland may not overgrow. There is a portion of it, and it's a good number actually, that last gland in time grows large enough to give the patient trouble. So those two scenarios exist. But these patients generally lead a normal life. The problem is that some percentage of those patients develop hypoparathyroidism because all the glands were removed, or the gland that was left behind is not functioning. So and generally that happens more often when you do auto transplantation into the muscle, because when you do that, 80% of the time it works and 20% of the time it doesn't work. And when it doesn't work, then there's no parathyroid function, right? I find that when you leave the gland, the fourth gland, in place with the blood vessels intact, and you just do a tiny biopsy and confirm with PTH that it's working, that the success rate is significantly higher, that the chance of it not working in the long term is 1% as opposed to 20%, right? Something along those lines. And so that's what I would say. And otherwise, am I fixing one problem only to cause maybe a bigger one down the line? Well, if during your surgery enough parathyroid gland is left behind where the blood vessels are attached and functioning and it's producing enough hormone, then you are not replacing one problem with another. You're actually correcting the problem. And that's really key in you finding an expert surgeon who knows what they're doing in order to leave the parathyroid behind, check the hormone level, confirm during surgery that you are not hypo, right? So that's really the key. Also, is weight gain, water retention, or itchy patches of the body a symptom of this disease? Weight gain is earlier on in the disease, and very late stages of the disease, weight loss happens because the intestines are just not functioning properly. The patient's not feeling well. The person is just not feeling, they're feeling horrible. They're not eating. They're not active. Their body's just wasting away. So it can be. Itchy patches, I have seen patients who have hyperparathyroidism complain about rashes, right? But I don't know if they were directly correlated, right? Because rashes are fairly common. Water retention, I've had only a few patients have water retention issues, so I'm not sure. I'm still in the midst of D3 supplementation test. Hope to update you soon. Thank you. Good luck, Susan. Ian McTavish. Hello, Ian. Good to have you back. All right. This is, Ian, I'm assuming this is follow-up from your surgery, that your calcium is in the high normal range. And your thyroid is working properly. Well, it looks good. Hopefully things continue, my friend. All right, Marjolaine Regine. Hi, Dr. Klein. This is March from London. Hi, March. I hope you're doing well. I have persistent hyperparathyroidism, seated adenoma, and no cure so far. After 4 surgeries, one of my symptoms is bloating of my abdomen. Ideally, I'd have a successful surgery, but since I'm not sure I'll be able to get to that point, is there anything else from hyperparathyroidism point of view that can be done to prevent my bloating? I'm not sure what part of the hyperparathyroidism causes bloating to begin with. Thank you. Hi, Marge. Obviously, it affects every system in the body, but specifically in the intestine, it creates low motility and low movement of the intestines, so they don't pass things along quite so easily. And because of that, both food and gas get trapped in the intestines, and the intestines fill up, and that causes bloating. And so, Marge, if you've had 4 surgeries without success, which probably either means that you have seeding of one of the parathyroids all over the place, or more likely you have what the condition we call parathyromatosis, which means that as your parathyroids were migrating from your throat down when you were a fetus, they left multiple pieces, right? And so in order to treat that, you have to do an extensive surgery where you clear out everything from here to there and clean the whole compartment up in order to have success. So that's the surgical route suggestion, if that's the route you want to take. Or you may want to take Sensipar and bring your numbers down and see how much of an improvement you get. I mean, although it's not ideal to be taking medications for the rest of your life, it's also not ideal to live with the bloating and I'm sure all the other symptoms that you have. And so I think testing it out and seeing if medications are able to help you, right, get control. And you may ultimately adjust this. You may take the medication, feel better, start exercising more, being active more, doing more, and increase your bone mass, therefore grab more calcium out of out of the bloodstream, drink lots of water to filter the calcium more, so on and so forth, and be able to get better control of your body that way once your numbers are down, and then potentially come off the Sensipar and see or maybe even decrease the dose of Sensipar. So there's many different ways of approaching this, but I think you may be locked into either repeating a more radical surgery or using Sensipar to segue into better health, right? And Aria, could primary hyperparathyroidism explain a very sudden weight drop, around 22 pounds in a month? If it's causing anorexia and if it's causing constipation and heartburn, then it could, because you're just not eating and so on. But that kind of weight loss, Anna, is dramatic and worrisome and concerning, and I would really look into it and do more involved search to figure out what the cause is, and not just put it on hyperparathyroidism. Even though it can cause it, you really have to look to make sure there are not other things at play, all right? Because that is a hugely dramatic drop. Brenda Berg, is it normal for PTH to be in the hundreds following parathyroidectomy? I take 4,000 units of vitamin D a day. My PTH won't stay down. Luckily, right now is at 78. My calcium alternates between 9.3 and 10.3. I had 1 gland removed. My brother had all 4 with a piece put in his arm. He's now has low calciums, and I don't really want to keep having surgeries and end up like him. And I already have osteopenia. I'm so sorry, Brenda, to hear this, and I'm so sorry for your brother, because he is, I'm sure, suffering more. But as I explained, the surgery that your brother had is not necessary at this point in time. That is not the way to do this surgery anymore. Autotransplantation, just like you see with your brother, has a failure rate that, in my mind, is not acceptable. And yes, you can have a successful surgery, but I would say at least wait 6 months. It is not uncommon for people to have high PTH levels after parathyroidectomy, right? And nobody knows the real answer, the real reason, but I suspect that it's because when you have hyperparathyroidism and your calcium is elevated, it's not an elevation in calcium because you're taking too much calcium supplements. It's because the PTH is drawing calcium from your bones. So overall, your body has a deficit in calcium. Your blood has too high. 98% of the calcium is in your bones, and 2% is in the bloodstream and the rest of your body, right? And so the amount that's in your blood, even though it seems like a high number, it's not a dramatic amount when you compare it to the whole body amount of calcium. So again, when your calcium is high, when you have hyperparathyroidism, you actually have low total body calcium because it's coming out of your bones. It's getting leached out of your bones, right? And so the important thing is that sometimes after surgery, your bones try to get that credit back. And when they try to get that credit back, the calcium in your bloodstream goes down, and then your parathyroid, your remaining parathyroid, start fighting with it and keep pumping out PTH to try to fight and balance and get calcium into the bloodstream, the amount that the body needs, and your bones say, give it back to me, you've taken too much from me, and this fight ensues, and that's what makes sense to me. I'm sure it's more complicated than that, but we're not clear on that. And so I would say at least wait 6 months. Do the vitamin D supplementation, do exercise to help force the rebalance, and be active. And then at the 6 month mark, reassess. Sometimes this process takes up to a year, right? Hopefully you don't have hyperplasia, you had an adenoma. I would also suggest that you read the pathology report to see if they could clearly see that it was an adenoma and not hyperplasia. And the only way they can tell with certainty that it was an adenoma is if they see this. Let me flip here. Okay, so the only way to know is when so this is normal parathyroids under a microscope. The dye is a little different. This is more percolation. This is more pinkish fuchsia color. The difference is the amount of fat. So these white things are fat. So normal parathyroids is half fat, half cells. Abnormal parathyroid has less fat. You can see this is like 75-80% cells and 20% fat. But you can't tell if this is a hyperplastic parathyroid gland or has hyperplasia, or is the parathyroid adenoma. The only way to tell if it's something is a parathyroid adenoma is if they have a normal parathyroid with hypercellularity, these are blood vessels, right? And a rim of normal parathyroid that has half cells and half fat. So that rim of normal tells you that one parathyroid cell over time grew to become a tumor, right? And at the edge of it, the normal parathyroid that this was in, so again, normal parathyroid has one cell that in time grows, duplicates, gets bigger and bigger and bigger, right? Bigger, bigger, and bigger until it has only a rim of normal parathyroid at the edge of it. Okay? And that's the only reason. So look at the pathology report. It'll tell you if you had an adenoma, right? And so it'll give you more conviction that what you're doing is right, and in time it'll get better. Okay? Best of luck, Brenda. That is hard, especially having a brother who's gone through what he's gone through, and you've seen it. So I can see how hard that can be for you. All right, we have 3 more questions. Ray Brown. I would like to ask a question that has come up several times in our group during the coronavirus pandemic, which is whether having untreated hyperparathyroidism in any way puts people at increased risk of having COVID-19 severe, or is it just other coexisting conditions that may or may not be related to hyperparathyroidism that makes some people particularly vulnerable. We know for a fact that people who have hypertension, high blood pressure, are susceptible to COVID-19. People who have hyperparathyroidism also are at increased risk of developing hypertension. So if that correlates or not, I don't know. I don't know if it's the fact that hypertension causes blood vessels to not function properly and blood flow to not be appropriate to all parts of the body that makes it more susceptible for someone to get infected, or is that just an indication of an aspect of the physiology that makes it susceptible? Or is it part of the thing? Because high blood pressure is more likely in people who are overweight. And is it the overweight, not the blood pressure, that's really the problem that makes your body weaker, because you have to service more tissue, more body mass right? And therefore your immune system has to do more work to keep all of this in check. And if that's the reason, so the issue is complicated and not clear. I would say that if you do have hyperparathyroidism, right, knowing that hyperparathyroidism causes inefficiency of every organ system, then that may be putting your immune system at risk of not functioning properly. Now, a lot of people who suffer from hyperparathyroidism and that's a signal that I have patients I have to take off. I got a warning. So if you have hyperparathyroidism and everything is working inefficiently, it could be that your immune system is working inefficiently. Now, most people who suffer the severe consequences of COVID actually have an immune system response that's inappropriate and overreactive, and that's what causes the complications. It seems at this point that seems to be the case. And so does that put your immune system at risk? Yeah. I mean, if your immune system is working inefficiently, it may be more prone to making errors and mistakes. So I would say to my parathyroid patients to be more cautious during these times. There's too many unknowns, and I would think that you are a little bit more vulnerable than someone who doesn't have hyperparathyroidism. Okay? So a long way of answering that question. And additional questions. Parathyroid patients tend to have low vitamin D levels. Could these put them more at risk of COVID-19? Well, vitamin D is an important vitamin for the immune system. So I think having low vitamin D makes your immune system be more prone to getting an infection. So yes, I think that also is a factor. Very good point. Ray, I think you know what you're talking about, my friend. Carolyn Coyne. I was told 2 years ago by my endocrinologist I had secondary hyperparathyroidism. My calcium is normal. I've taken 3 vitamin D, 3 tablets for it. I have to take 3 vitamin D tablets for the rest of my life, and he sees no point in further tests. I disagree with your endocrinologist wholeheartedly. Hopefully he or she is correct, and you have secondary hyperparathyroidism, and the vitamin D corrects it. But you have to do testing to see that, right? So if you take the vitamin D for a period of time, and let's say your calcium is 9.8, right? And your PTH is 75. So 9.8 is normal, in the normal range, kind of mid to upper normal. And PTH is 75, elevated, but your vitamin D is 10, low. Vitamin D suppresses PTH production. And because it's suppressed, that at low vitamin D, it can't suppress it, the PTH production goes up, which bring the calcium level higher with it. Although it's still in the normal range, it's higher. And if you take vitamin D and your PTH now comes down and it's now 20, 30, so on, and your calcium is either the same number or a little lower, then yeah, you had secondary hyperparathyroidism, life is grand. You should always remember to supplement and always remember to check your vitamin D, calcium and PTHs in the future on an annual basis, just to see what your numbers are doing. And if again what you're taking is not adequate and you become secondarily, because secondary hyperparathyroidism can have consequences too, and so you know when to adjust it. So I disagree with your endocrinologist wholeheartedly, because you need to continually check it first to see if you did confirm that you had secondary hyperparathyroidism, right? That it wasn't primary along with vitamin D deficiency, right? Both happening at the same time, because that can occur, right? And so hopefully that's not the case. You have secondary hyperparathyroidism and the number's correct. And then in the future, you need to test to make sure you don't keep getting it, right? And that would be my position on it. I think I am a great fan of supplementing vitamin D3 and vitamin K2 along with it, but I am not a fan of supplements as a whole for an entire lifetime without knowing why you're doing it. I really firmly believe that we have evolved with eating foods and getting our products from foods. The fact that we need vitamin D3 is an evolutionary thing that developed in us, right? And so we've co-evolved with nature, right? And so we never evolved with supplements. So if you can get your body's needs through natural means, it's always better in my mind. right? Because you get more comprehensive replacement of stuff as opposed to high concentration of 5 or 6 chemicals in a supplement, right? Or one chemical. In any case, that's the path I would say to take. And we are now at the last question. How do you rule it out because you feel bad, but the numbers to me are normal? But they want higher numbers. Either way, I'm sick, I'm the one suffering. What definitives should the glands do? Oh, this is JDM 19654 on Instagram. JDM, I would say you need to graph the numbers, right? I say this all the time. Make a table, graph calcium. If you have free calcium or ionized calcium, do that too. PTH and vitamin D. Look at these 3 numbers over time and to see what trends there are. If your calcium and PTH are doing this thing, inverse relationship and going up and down, and your vitamin D is normal, then you don't have hyperparathyroidism, right? If they're doing this thing and your vitamin D is low, then replace your vitamin D, take supplements, and see if you can correct these numbers, they can bring them down and get them to do this. If they don't do this and they stay at the same level, then you have hyperparathyroidism. If you look at your numbers and vitamin D is normal and your calcium and PTH are here, let's say high normal calcium and your PTH is high normal and goes up and down and your vitamin D is normal, then you have hyperparathyroidism. And that's all there is to it. So I think you need to look at the trends in order to get the answer. In any case, this brings us to the end of our Q&A session. I hope this has been helpful. Please stay healthy, please stay safe, please stay smart. Please do your own search. As you've seen with hyperparathyroidism, medical information is not necessarily always so clear, and not all medical professionals are experts at this. So in terms of what I would say, the leadership that we have all around the world telling us what to do, I would say get more information yourself to make the right decisions about your health altogether, about Corona and COVID-19. Be safe, be smart, protect yourself, protect your family. Unfortunately, the Corona is real. Unfortunately, when your body misreacts to it, it does it in a tremendously horrible way, and we still are not smart enough to know what those steps are. So please be smart. All right, take good care.